Good afternoon, everyone. Today we are talking about polycystic ovarian syndrome, what people mostly call PCOS. So PCOS is the most common endocrine disorder that affects women who are in their reproductive age. And in that case, I'm talking about 15 to about 45 years. It affects about 10 to 30% of the women within that age. And of the women within that age group that have PCOS, about 50 to 60% of them will have fertility problems. So that's how common the disease is. PCOS normally comes as a result of a dysfunction, what we call a dysfunction between the hypothalamus, the pituitary, and then the ovarian axis, what people call the HPO axis. And in the end, it will give you what people normally call a hormonal imbalance. The hallmark, the end product of this hormonal imbalance is basically anovulation, which is failure to ovulate. For you to have PCOS, you need to have two of the three features I'm going to talk about. The first one is irregular or infrequent or absent periods, what we call amenorrhea or oligomenorrhea. Oligomenorrhea, that's where you find that your cycle is very long, above 35 days. To some cases, it even goes up to 40 days. So that is one. The second part, you need to have what we call biochemical or clinical hyperandrogenism. This is the presence of excess male hormones in a woman. For the biochemical, when they do your lab tests, serum testosterone and the androgen free index, usually they are a little bit elevated. For the clinical hyperandrogenism, this is where you find there is presence of male features on a woman. Things like beards, what we call hirsutism, and the presence of acne. The third part is the presence of polycystic ovaries, and this is usually seen on scan. So if you do a transvaginal scan, the ovaries are seen as polycystic, which is usually a count of 20 or more, or a volume above 10 cc's. We normally manage the disease according to the goals of the patient at that point, because it presents in different ways. If the person is to have a regular period, we manage that. If the person wants to conceive, we go ahead and treat that. If the person wants to lose the male or the hyperandrogenic features, we go ahead and treat that. So, these are the different treatment options. The first one is diet and weight management together with exercise. Sometimes these are enough to return your menstrual cycle to normal without using any drugs. Now, when we move from that, we go to pharmacotherapy. That's where the drugs come in. Drugs like metformin. The role of metformin is to decrease the insulin resistance. As you take the metformin, sometimes this is also enough to give you a regular menstrual cycle. As long as you are having a regular menstrual cycle, it makes it easy for you to conceive as a woman. The other drug are the myoinositors. These ones also help to improve the insulin resistance. They shorten the cycles and basically improve the fertility outcomes. But if you want to just achieve a menstrual cycle with no fertility ambitions, in that case, your practitioner may actually start you on oral contraceptives and anti-androgenic drugs, things like spironolactone. These will improve your appearance as a woman. The hair may disappear and the acne may disappear. So in most cases of polycystic ovarian syndrome, we manage them with just diet and drugs. Very few cases will need surgical intervention. And in case we are to do surgical intervention, we normally do what we call laparoscopic ovarian drilling, where we go and remove these immature follicles from the ovaries to give the ovary a chance to regenerate and recruit newer antral follicles, what we call the newer eggs. So polycystic ovarian syndrome is very common. It is common, but it is treatable. No matter how it presents, it is treatable. If it presents with the menstrual disorders, we can't treat that. If it presents with infertility, the infertility can be managed. Once you have PCOS, it doesn't mean that you can never conceive. Thank you.